Dr. Gordon as he talks about more thoughts on caring for our bodies, and we just trust you with strengthening us and growing our faith and deepening our love for you. In Jesus' powerful name, amen. All right, Bonnie, have fun.
What about the other one today? Awesome. Good evening. How are you all? Are you baking to death? Anyway, welcome to this event. And what I did is, because it's so hot, I tried to put together several recipes, and we're going to do the first two, the Middle Eastern salad. I'm going to demonstrate that tonight, and we're going to just serve you a fresh watermelon salad on the back side, okay? Sorry about that. That's wrong. We're going to do the fresh. We're going to serve you the fresh watermelon mint salad. There, I'm not going to demonstrate it because there's only 3 ingredients, okay? And we're going to do the corn, blueberry, and wild rice salad, okay? It's very colorful, and it's really quite delicious. So, anyway, when I was asked to do this, I offered to do it because I love summer and I love the beautiful fruits and vegetables that are so readily available. And so when it actually came time to do this, I thought, what am I going to do? So I thought, watermelon is so good for us, but I didn't know the real benefits of watermelon. And so I Googled and I found 10 benefits for watermelon. One is it's front-loaded with essential nutrients. It offers a big dose of lycopene. What? He's going to talk about it. Lycopene. And Gordon's going to talk to you about lycopene and the blessing of it. Your watermelon is sweet, but because of all the water in it, it actually lowers the blood sugar in your body. Isn't that amazing? It is so amazing. I just thought, wow, Lord, you're so fabulous. And it keeps you hydrated. It adds to healthy digestion. And it helps with weight management. And may improve your heart health is another benefit. And can work to reduce cancer risk, and it helps to reduce inflammation, and it's great for your skin. I have issues with my skin. I don't know that a lot of people know that, but I have something called rosacea, and you can break out at any time, and it's rashes, zits, everything you can think of. But when I take watermelon in the summertime and have it on a regular basis, I have it at least once or twice a day, I don't have to be taking my medication. So I really, really appreciate how God created the watermelon to be a benefit, not only for inflammation, but for people's skin problems, keeps us hydrated. God is so good. We just need to always, every moment of every day, thank Him for His goodness and His mercy towards us. And then the last thing with watermelon is that it may relieve achy muscles. So, and I think that just by being hydrated, that is a real blessing for the whole body. Then we're also going to cover mint, the recipe that has the fresh watermelon has mint in it. That's one of the 3 ingredients. We put a little bit in it. And what do you think mint does for us? What's one of the main things it does for us that you notice? Say it louder, Susan.
Helps your bad breath.
That's right. It takes away that bad breath. You can have a whole bunch of garlic, and then you bring some mint tea, and you go out in the garden, you eat some mint, and that bad breath is all gone away with. And it's wonderful to help in supporting the digestive system. It's a perfect detox. I don't know what kinds of things people would need to be detoxed from, but it will help with the detoxification if you have it. And it's also helpful for coughing and colds, and I know that in the wintertime we're more susceptible to that. So what I do is I dry my mint because it grows like a weed at my place. So if anybody wants a fresh mint plant, call me and I'll plant something for you, and you can have your own mint. In about a month you'll have a nice little bush of it, and you can, the more you cut, the more it grows. And it helps with coughing and colds, reduces respiratory problems. It soothes a toothache. It's also known to help and benefit headache relief, anxiety reliever, and rejuvenates your skin, and it's full of antioxidants. So there are so many benefits in the foods that God has created and made for us that we just take for granted. Half of us don't even know half the blessing of what we're eating. And it's nice to have a refreshing little introduction to some of the food that we're going to be presenting tonight. So I'm going to present to you, and all of these are cold so that when it's hot outside, you don't have to turn your oven on, you don't have to have your cook stove on, you can just stir it up and enjoy it. So if you'd like to follow along, we're going to do corn, blueberry, and wild rice salad. And it can be ready in 15 minutes, and truly, that is the truth, okay? Because I made a single batch 2 days ago just to test the timing, and it took me about 20 minutes. I'm slower than most people, but that's okay. And then what I did is I cooked up a bunch of rice, and I freeze my rice so that if I need it, spur of the moment, I can just take it out and thaw it and use it for anything else. So that's really a nice thing to be able to do. So make more rice, and then you'll have it for other occasions. So the first thing we're going to do tonight is we are going to make the dressing. And the dressing starts with 2 tablespoons of lemon juice. Now what I've done, I'm going to stir that in at the end. Oh boy. I'm going to have, what I need is, no, I want to put this in the microwave for about a few seconds, okay? Just let me put 2 tablespoons of this in. And I don't have a full tablespoon, so I'm going to add a little bit more. Okay, so that's our lemon, and the salad dressing has 2 tablespoons of lemon juice and 2 teaspoons of honey. I doubled that because the lemon gets kind of, and then it's salty. So I had a hard time tasting the honey, so I just added extra. And then a half a teaspoon of cumin and a teaspoon of salt. And then I'm gonna let Rebecca just probably for 15 seconds. Yeah, thank you, honey. So, and while that's just getting warm so that it will blend nicely with the ingredients that we're going to put in, we might as well go ahead and start with the corn. So we have a cup and a half of corn. And corn adds sugar to it, but you really don't taste it in the salad itself. And then a cup of blueberries. And it says that you can have a cup of wild rice or black rice. And I had some black rice, and I cooked that up, and I had some brown rice, and I just mixed it because I thought it looked prettier. Okay, and then After the wild rice, we have what? Awesome, thank you. Thank you, thank you. What do we have we have cucumber. And it's watery and fresh. It's so good. And then we have a quarter cup of red onion. And this is chopped up cilantro, a quarter cup of cilantro. Most of the time, I only eat cilantro with Mexican food. But this is different. And it tastes good. And my fingers are clean. Okay, and we're going to just mix this in. So does, pardon? I put cumin in, I put the cumin in cilantro. I'm sorry, did I say cumin? I chopped up the cilantro and I put the salt and the cumin in with the honey. Okay, so that is there, yes. I just thought it would be easier if I combined all that together. So, here's your fresh salad. Isn't it pretty? It is it's just lovely and good to eat. So we've made up a bunch of it for you. Okay, we're ready for. Anybody have any questions? I think it's pretty self-explanatory. Yes.
Hey, Bonnie, does it make a difference if you use spearmint or peppermint for the?
I haven't tried that, but you know something? I bet it would be delicious.
So it doesn't have. You find it would.
Yeah. Yeah. This is, to be honest with you, when I was planning this, I was at my wit's end. I didn't know what to do, so I talked to my daughter, and she gave me this recipe. So I'd never had it before, and I made it. Gordon, I made it according to the recipe.
Oh.
But people are free, if they don't like cumin and don't like cilantro, try mint or try basil. There are just so many different kinds of herbs that we could try, even maybe rosemary. Do you like that strawberry? Yeah, and that has a little bit of mint in it. So, and with the mint, let me see. So with this, here we go. There are, with the fresh watermelon mint salad, which you're eating right now, there are some suggestions. You can add agave if your watermelon isn't sweet enough. You could substitute the mint with basil. But you know, if you want, you can try it, okay? I'm going to try it sometime. And then you can also add blueberries. We had extra blueberries, so we did that tonight. We added extra blueberries. And to make it more zesty, I did not put any lime or lemon in the watermelon salad. But you can put lime in it. Just to change the flavor. When you have watermelon, you have so much of it, and you wonder what you're going to do with it. And just to add something different, and it gives a different twist. And I was out at Gordon and Rebecca's last summer. I grew up on a farm, and I had 4 big brothers. And so there was never anything left over. So when so we were at Gordon and Becky's, and they had watermelon, and I said, "What you want to keep this?" And they said, "Oh yeah." Next thing I knew, they were grinding it up for juice, and it was absolutely delicious. So you can juice watermelon too. And put a little bit of, and then maybe you could even. Have you ever tried putting it in the freezer and making it into a smoothie? Gordon?
Yes, we have.
You have.
Yeah,
Do you like it?
Yes. If you travel to the Far East, I mean, like China, they have a lot of watermelon puree and cantaloupe puree.
Cantaloupe and watermelon what?
Or puree, like they.
Oh, puree.
Yeah, puree. Yeah.
Okay. Oh, it is delicious. It was a whole new thing, because living on the farm, there was never any watermelon left over. So, and then there were a couple of other things that you can do. If you want to make it, you can put that salad into, like, cut up arugula and make it into a green salad. Okay, that's the fresh watermelon mint salad. They have suggestions right here for the things you could do. Okay, and I just thought it'd be fun, and you can put jalapeno in it if you like. And another wonderful thing: do you have how many have got grandchildren? And do they ever come to visit? And you don't know what to do with them? You get a watermelon, you cut it real thin, the size of a little cookie cutter, and you give them a cookie cutter, and then they can make stars and hearts and flowers and all kinds of things. Okay? Any questions? Hi, guys.
Bonnie, thank you very much for giving this presentation.
Oh, you're welcome.
Very smooth. We're giving her a hand for. Sure, yeah.
Grateful we are for your love, for your grace, for your mercy, and for providing for all of our needs. And we just look at the foods that you have provided for us to eat and to enjoy, and then to come to realize the nutritional value of what they do for each one of us if we prepare them according to your will. Pray that you'll bless each person here tonight, and that you will guide and direct us as we leave here and we adventure into different things to prepare to eat, and that it will bring healing and happiness to each one of us. In Jesus' name, we thank you and we glorify you and just praise you. Amen.
Amen. All right, we're going to have everybody move over here to right before the projector. There you go, Steve. Yeah. Come on over here. Hi, Jen. Good to see you. Oh, it's okay. Yeah, grab a seat. While everybody's getting seated, Wanda brought in a BMI machine over there. So it weighs you, and then you input your height, and you get your BMI. Of course, I think it overestimates me all the time. I'm supposedly obese or overweight, one of the two. So, but anyway, you can find what the number is, and that way you can figure out what the doctors or the nurses are actually talking about. So I would encourage you to try it once. If you have any trouble with it, let me know for the BMI. Does everybody know what a BMI is? Body mass index, yeah. Okay, so hey, I'm actually excited about this talk because it has information about how to take care of yourself. And I've been looking for a book that had information like this, and I finally found it. And I wish I had found this book 20 years ago. I think I would have done a better job taking care of people. So 50 years ago, I finished a residency in family medicine, and it dealt with this, but it was never in one place. So you had to know just about everything. And so this thing summarized it really well. I'll show you a picture of that book. But anyway, It says, planning for a healthy future. Take a look at your current status and then take steps to protect your future. If you have health risks, it's time to start reducing them. A healthier lifestyle can reduce your risk for multiple medical illnesses that might otherwise limit your lifespan, undermine your independence and quality of life. So basically, we're trying to find ways we can have better quality of life and live longer. And be independent. Independent means you don't have to be reliant on a wheelchair or a cane or a walker. So you want to stay healthy, and that's the reason why we do this. Okay, and these were the two books from Harvard. It says it's men's health and women's health and 50 and forward, but actually it applies to anybody who's probably above 25. It has information on that. I found it really helpful. I mean, it was just like in one place. Okay, I'm going to start with the first one. This is what we're dealing with today. I have an hour to do this, or a little more. Talk about your prostate, erectile dysfunction, like, changes in vision, reducing major illnesses, prostatic cancer, colorectal cancer, Alzheimer's, persistent menopausal symptoms, pelvic organ prolapse, ovarian cancer, dry eye syndrome, some major things and some minor things. I'm just going to cover it. The reason you really want to know this is because when you go see your doctor, you really do want to know what to ask for. And if you don't know, this will help you get an introduction to this. And in a way, I wish I'd known about some of this information that was on the booklet. I was just going through it because my mom was going through a lot of stuff. And I didn't know some of the information, and I couldn't help her at all. So I feel really bad in some ways. So I'll explain the ones that are easy to not know very much about. And not all the doctors know, because I took her to a number of doctors and they didn't know. And this information is here, so people do know about it. Okay, benign prostatic hyperplasia. I'm not going to ask who has this and not has it in this audience, but I'm sure I have it. Yeah, I'm sure I have it. Man, what's so funny? So this is not cancer. This is benign hyperplasia. Most of the men have it, so you got to have it. So the prostate gland, I'm going to show you in a second here, but it produces semen, and it's enlargement of it. And there's right there if I can get the laser to do it, there's a prostate that's normal. You see it, that yellow thing, and then when it's large. And you can see the bladder up here. The urine comes through here, through the urethra, and out the tip of the penis, and the urine comes out. But when it enlarges, there's a small opening. I don't know who else has this thing, but I have to admit I have it. So it causes leaking and dribbling urine, and your stream that comes out when you pee, it doesn't come out very strong, and you have to go to the bathroom a lot. You have to go to the bathroom at night, frequently. And I see people nodding their heads. In addition to that, the bladder wall thickens. So you see how this wall is thickened compared to the normal one? See how thick it is? Because it thickens, it reduces the volume and the elasticity. What I mean is, like, when it squeezes to go, it doesn't squeeze hard enough. I'm going to actually turn a light off here. So what that means is you're going to have trouble when you go to urinate, and you may have trouble when you try to urinate. And I started noticing it about 5 years ago. Okay, so this thing, again, benign prostatic hypertrophy. Some of the solutions that Harvard printed out for their doctors to recommend to their patients is that you avoid drinking fluids in the evening, particularly caffeinated alcohol, because it affects the muscle tone and causes the kidneys to produce more urine. In addition to that, you should avoid antihistamines and decongestants. And a decongestant is like Sudafed, because when I take Sudafed or decongestants, I have trouble making that urine come out. It's true. I mean, when I saw this, I said, wow. And there are certain medications, just like antihistamines and decongestants, that can slow it down. And the solution for it is there's an alpha blocker. It relaxes the muscles in the prostate, and that medicine is called Flomax. I think my mom was taking it, although this is mainly for men. And the 5-alpha reductase inhibitor, it makes the prostate get smaller. I want to show that again, going backwards. See how big the prostate is on here? Yeah, it's enlarged. And that's the medical way of treating it. Their surgical way of doing it is what this guy's doing right here. He's looking through a scope. He sticks it down through the penis, through the shaft, and then he does what they call a rotor-rooter. Yeah, I know. It doesn't sound good, but it's like close to 95% successful. I mean, it's almost a guarantee it'll work. But it does have its own problems. I'm not going to go into it. It's this is a short talk. Or they try to burn it with electrical vaporization, or they use a laser to, basically, you see the scope is right in the dark section, right here. That's the prostate. They're opening, making the opening larger. Basically, like if you do a rotor-rooter, you're opening making it easier for you to urinate. Okay. The next one is, they thought was important enough, they put it second in the booklet. Erectile dysfunction. So, sorry. Okay, but as a man ages, he's less likely to have a firm erection, particularly if he has heart disease. And the treatment is, medications such as Viagra, Cialis, I don't even know all these names, but they're inhibitors. It's a blocking enzyme that interferes with the erection-producing chemical. And so what it does, it blocks that chemical, increases the blood flow to the penis. Other solutions is to inject into the penis just before you act, or drug pellets that go into the tip of the penis, and vacuum pumps, and penile implants. So I only bring this up because it's when I was in primary care, I didn't have that many people asking me about this, but I imagine if I had stayed there longer, there would have been people asking me. Okay, there's other things that happen that affect men and women. Presbyopia. Presbyopia. Does anybody know what that is? Yeah, so that's right. She says, so basically your eyes, the lens starts stiffening, and it has to change the shape to focus. And if it doesn't focus, it focuses wrong. So you can't see things close up, but you can see things far away. That's where it is. So I noticed when I was about 40. I'm 68 right now. And at 40, I was having trouble. So what they do is they put contact lens. They put one eye, they have a far vision, so you can see far, and then put another eye, another contact that sees near. And you're just basically compromising. That's one solution. Yeah, or you can wear glasses that do that. And you can also do a multifocal lens implant. So implant is when they have cataract surgery, they put a lens inside there, inside the eye, and then they can refocus the image or light into the eye correctly. Some people do LASIK surgery that corrects it. So those are other things that you can do that people have as they get presbyopia. The other one is cataracts. With cataracts, you have blurred vision, and you have trouble with glare, difficult even when wearing glasses. And the solution is actually a very simple surgery. It's like 5 minutes, and the risk is low, but you still want somebody who does it really well. And that's to remove the lens and then replace it with another artificial one. The other one that there's what we call hearing impairment. Hearing impairment means that you have trouble with high frequency sound, high frequency, So the low frequency, usually you're okay. So most of the hearing aids can be selected to do to make up for the high pitch and not accentuate the low frequencies. And you can also make sure you're not taking medicines that cause you to lose your hearing. I wonder if that's what happened to my mom. Or you can do a surgical implanted device and you do hearing aids. The bad thing about hearing aids is usually it's not covered by Medicare, so you have to cover it yourself. And this is the problem that Becky's saying I'm having, that I can't hear. I don't hear her very well. So she thinks I have selective hearing loss. Yeah.
Just be married.
Yeah, just married, yeah. So these are things that they deal with. This is in the sequence. It was in this Harvard text. Next one is pain and low back pain. 4 out of 5 Americans are have back pain without really any clear identification of what causes it. Now, ones that we do understand is like herniated disc and other things like that. But 4 out of 5 Americans have low back pain, like I have low back pain. And it says that the treatment for it is like heat and cold, limited bed rest. So the idea is not to go rest in bed. I mean, you can rest a little bit, but not to stay in bed. You'll get deconditioned if you stay in bed. It's better to get back up a bit and start walking. And some of the other things that help it, they found for sure, is physical activity. Start doing your activity, starting to get into, so you can actually exert your back, and also do core exercises to strengthen your stomach and your back. You have to do it. If you don't do it, you're prone. As soon as the pain goes away, like in 2 weeks or something, it'll come back again. And so the idea is to strengthen the core exercise. Do core exercise, strengthen your back and your stomach and everything, because it stabilizes the back. So you have less likelihood of this happening. And so what I usually tell people, because it was within the realm of orthopedics, is wait until the pain's relieved. If you have to use all types of different medications or whatever, or massage or hot and cold or whatever, once it goes down, you have to start doing core exercises. So you strengthen your back so that you don't get a repeat episode, or at least prolong, or make the episode next time it comes longer time frame. And at the same time, look out for red flags. And red flags are like you have back pain and fever, weight loss, or you have a prior history of cancer. Because one of the big things in cancer is back pain. That's one of the things, because a lot of the cancers spread to the back. They go into the vertebrae of the back. So that's why you still have to be really careful. So if it goes too long, you got to start thinking about it. And what I mean is, like, if it goes beyond 3 months, or and it doesn't seem to be relieved, you have to start looking at other possibilities. Otherwise, most of the simple ones, you get some bed rest and get some physical activity or physical therapy, and you do pretty well. Next one is pain from osteoarthritis. Osteoarthritis is a big thing. It's the wear and tear arthritis. It's from basically using your muscles, and you're doing activities that will cause wear and tear. And it's usually in the joints and the cartilage. Now I'm going to show you this thing right here. See, this white material is the cartilage. If you ever seen a turkey bone, when you look at the drumstick thing, there's a white covering on there. That white covering is the cartilage. You only get one. We used to tell people you only get it once. So you want to protect the cartilage as much as possible. So guys that played a lot of sports, they have more issues with it, because once it gets dinged, it doesn't come back. So you only get one. It's called hyaline cartilage. That's what is in there. Now sometimes you can make it come back a little bit, called fibrocartilage. That's what we used to do for surgery. We try to give them a new cartilage. It's not as good as the hyaline cartilage, which is you're born with. God gave it to you. So it's and if you look at this, the right side of the knee, the red represents where the cartilage is gone, and you'll see bone spurs. It says bone spurs. there's extra like bone forming because the body is trying to lessen the pressure. So if you push down on like this, if you widen the area that this my fist is pushing on, it'll spread the pressure. So instead of weighing, like say, 5 pounds pushed here, if you push it out wider, maybe it'll be only 2 pounds. And that's what the bone spur does. It widens the surface area it's trying to contact. And so that's what osteoarthritis looks like. And the treatment is, you can try heat and cold, physical activity, and losing weight helps a lot. And like if there's a 200-pound man, he has about 600 to 1,200 pounds of force during normal activity. So losing weight helps. Physical activity helps. They actually study people that actually were having osteoarthritis pain, clearly had osteoarthritis pain. Physical activity helped them. And they were able to back it up with a study. I don't have it with me right now, the study. The other thing is using a cane. And instead of a cane, you can do a trekking pole. There was a test question that came across when I was getting recertified in orthopedics. And it said, how much pressure or how much reduction in pressure would it help if you were to use a trekking pole or a cane or anything for your knees or your hips? And the answer was like 42%. That's almost half of the pressure will be taken off. That's why the trekking poles and canes are so helpful, because it takes the pressure. Now, it puts it through your shoulders, and hopefully your shoulders are good, but most people have good shoulders. They have more trouble with their knees. And surprisingly, this Harvard study recommended acupuncture. And they actually backed it up and said they actually had a study that say that it helped people. I think in the Tri-Cities it would be a little hard to find somebody that does acupuncture, sticking needles in somebody, but you found somebody that can do it, that's great. The other one is drug treatments for osteoarthritis is mainly anti-inflammatories, like Motrin and Tylenol. I want to say a few words about Tylenol. Tylenol is usually the safest one. I can take Tylenol. Only person that really can't take Tylenol well, like over-the-counter Tylenol, is people that have liver problems. So if you drink, so I know this group of people, they don't drink, but if you drink and you take Tylenol and you take too much of it over-the-counter, actually people have died from taking regular Tylenol, which is acetaminophen, because it's metabolized through the liver. And if you drink, your liver doesn't work that well. So the other one is NSAIDs. NSAIDs are like Motrin, Naproxen, Mobic, Celebrex. There's like 20 of them. The only bad thing about Celebrex, it causes ulcers, kidney damage, and heart attack and stroke. The risk is low, but it's there. So like I have kidney problems, so I can't take NSAIDs. I'm not going to take a chance on it. I'm just going to take the regular Tylenol and take my chance. But the NSAIDs, the advantage of the NSAID is it helps with fever, pain, and it's anti-inflammatory. Tylenol helps with fever and pain, and it has no anti-inflammatory properties. So that's why Motrin and Advil and all these things are so popular, because it has the anti-inflammatory component to it. The other thing up here is you can use topical creams. I'm just going right up here. There's some creams that you can use. My mom was using creams all the time, trying to keep their pain level down conservatively. So like Biofreeze, Aleve cream, and there's Voltaren cream, which is a non-steroidal type. And also, I don't know if you heard of it, how many people heard of glucosamine and chondroitin sulfate? Yeah, so those are like you go from Walmart or something, you can pick it up. There's not really solid proof it helps, but there's no solid proof it doesn't hurt. For sure it doesn't hurt you, but there's some question if it helps or not. Some people use it, and some people swear by it. So, but it was mentioned, and I thought I'd bring it up too. The other one is corticosteroids. It's a steroid injection into the knee. I don't know how many people have had it. I used to give it a lot. It helped people, give them relief temporarily, sometimes up to a year if you're lucky. If it didn't work, it was only for maybe a week or even a day. So steroid injections to the knee are beneficial. It can help you. And then the other one that people use is gels and lubricants are injected into the knee, and the only people that probably can afford it are Medicare patients. And it's a gel. It's the same components or composition as the synovial fluid in the knee. So, anybody use Synvis or Hyalgan? Once, okay. Didn't work, okay. Yeah, so, but it's expensive. It helped. Yeah, I was just curious. We usually we try steroids first, and then we if it said it didn't work, we just try to go for the gel. The gels are more expensive. That's the problem. Okay, and then for pain, arthroscopy, which is knee arthroscopy, is like a simple procedure. We put a telescope inside the knee and clean out the knee. It's probably good for people that have locking in the joints. Does everybody know what locking means? It means the joint clicks and then you can't move it, or it keeps on popping and clicking. And it'll mimic a meniscus tear. And then there's joint replacements, and the lifespan of a total joint, like this joint right here, total joint. See, it's made of metal, plastic and metal. And this is a total joint of the knee. And they're about 10 to 15 years. Sometimes I'll meet somebody that had a 20-year duration in there. And I think they're great. It's one of the most common procedures done by orthopedic surgeons now. Okay, next one, age-related memory impairment, protecting memory and depression. So this is talking about Alzheimer's. So Alzheimer's is the most common cause of dementia in people. So if you had somebody who was confused and not acting right, and it wasn't the medications, wasn't because they had a stroke or something, if it was truly dementia, probably the most common reason is they have Alzheimer's. Maybe early Alzheimer's or something like that. So we always look for other reasons so they could be demented or confused. And that's like, for example, medications, or they fell and hit his head or something. So age-related memory. So to protect your memory, this hardwood collection of information is not unique. Other places talk about this too. It says, they all recommend, and this on the slide on the right-hand side also says the same thing. And I was very surprised, but this is what they said. Eat a plant-based diet, a diet that contains abundant fruits, vegetables, legumes, nuts, and whole grains with limited animal products. And that came out, like I said, they were able to, this is what they wanted to disseminate. So plant-based diet, and exercise regularly because it helps bring blood to your brain. Get enough sleep. Getting enough sleep to me is important. Another one is manage your stress, and it says use it or lose it. So challenge your brain. What I mean by is, if you have activities that help challenge your brain, make you think, you'll live longer. You'll have less dementia and confusion. You got to stimulate that brain, make it use. And then the last one was wear a helmet when riding a bike. I was very surprised it was on that list, because people, when they fall and hit their heads, early injury to the head, and I hate to say this, probably because I used to cover football games for the high schools, and when people get head injuries, it probably predisposes them to having some dementia earlier, maybe their 60s and 70s. And so these are the reasons why you should protect how to protect your memory. There's also depression. It says 17% of men will develop depression, and women are more likely to be depressed, 1 in 8. And then men seems to have more issues. I already know this group of people I'm looking at today, there's nobody depressed. But it is a problem out there. So, okay. Now this was a big one too. So when we get older, beginning somewhere around the age of 30, we start losing energy and muscle power. I know people complain about that all the time. This booklet had an answer for this. And so if you have less energy, it could be because you're depressed, anemic, meaning you don't have enough blood in you, thyroid problems, which is like hypothyroidism, and chronic fatigue. And they don't recommend drinking more coffee or tea. They do recommend exercising more and sleep hygiene and stress management. And so those are things for energy. So the ones, if you went to your doctor and complained about not having enough energy, they'll run that thyroid test. They'll check your blood level. This is basically is textbook. This is how they're going to do it. And they'll look for some medication that could be causing it too. The other one here is reduced muscle strength. They actually gave a name to it. This is the first time I even was introduced to it. Sarcopenia. Sarcopenia is the gradual loss of muscle mass beginning age 30. So really if you look at this diagram here, this is a normal arm, average healthy adult. So this is the muscle after sarcopenia occurs. You see the red, which is the muscle, starts atrophying or growing smaller. So this is probably through the thigh. This is the femur. And the conclusion was, no matter how old you are, it's not too late to start exercising to preserve as much muscle as possible. And they found that even 6 weeks of progressive resistant training, which is like bands or weights, you can dramatically improve muscle strength and power as well as mobility and balance. So I think it's important because I try hard to go if I can get to the gym. Probably because I was in the Army, so is Ryan. We want to be strong. We don't want to be weak. And the more muscle strength you have, or muscle mass that you have before the age of 30, when it starts decreasing, you'll end up with more. Muscle mass when you became at 60. So we're going to start talking about different diseases. I'm going to start going through there. I thought this was really important. I thought this was well phrased. You can take steps to greatly reduce your likelihood of developing chronic illnesses, or at least reduce the severity of it by for example, problems like heart disease, cancer, and diabetes, which consistently rank in the top 10 causes of death, are years in the making. What it means like that, it took decades for it to come on. It didn't come on overnight. So it offers you multiple opportunities to intervene with lifestyle changes. So in other words, over that 20 years it took to develop it, you had multiple chances to intervene and counteract of early years of behavior and even override the influences of your genes. That last part, override the influence of your genes. So you have a chance to try to change this because you got decades to work on this. So it's not overnight, and you can actually change the course of your genes. So first one is heart disease. 1 in 3 men have some form of heart disease, and it's the leading cause of death in women. Heart disease kills more women than all types of cancer combined. So you're more likely to die from heart disease than you would to die from cancer. And there's the ones atherosclerosis, where it clogs up your arteries, heart failure because the heart doesn't pump right, or you have an abnormal rhythm. And the male risk factors are age, family history, race, and bad cholesterol, high blood pressure, smoking, diabetes, unhealthy diet, sedentary lifestyle, too much alcohol, and a bunch of other things. Now this is the female one, which is when I was going through school, we didn't learn this. And I used to take care of patients for heart disease all the time. Females, early menopause. So you lose the protective effects of estrogen. Not to say you should have estrogen, but when you go through menopause, you lose the estrogen effect. The estrogen protects you. Gestational diabetes. When you're pregnant and you become diabetic, there's a chance, because of that, you have higher risk for heart disease. And preterm birth, what it means, you gave birth to a baby that was before 37 weeks of pregnancy. They tend more to have heart disease in ladies. Stroke is the same kind of thing. Vast majority of strokes are artery blocked by blood clot, and this is also called a transient ischemic attack. It's called a mini stroke or warning stroke because many people who have a TIA will go on to have a full stroke. So basically, if you got a TIA once, you need to start thinking about looking to prevent another TIA or prevent the progression to a stroke. And women are more likely than men to have a stroke, and they have the same risk factors as heart disease. They used to have a saying, if it affects your heart, it also affects your brain, stroke, transient ischemic attack. That's the slide. Next one is prostate cancer. It's the second most common diagnosed cancer in men in the U.S. and the second leading cause of cancer death for men. And so I'm just going to go through it. The risk factors, family history, race, and this was straight out of the Harvard book. Men who eat a lot of red meat or high-fat diet or high-fat dairy products have a higher risk of prostate cancer. Conversely, foods rich in lycopene, such as tomatoes, pink grapefruits, watermelon, papaya, may reduce the risk of cancer, prostate cancer. So basically, red meat and high dairy products have been tied to prostate cancer. And I'm going to go through the symptoms. People would urinate frequently, blood in the urine, have erectile dysfunction, difficulty urinating, pain in the groin, burning with urination, and those are some of the symptoms of prostate cancer. So that's why we want a second leading cause, and it affects men. So you need most people used to do is get a rectal exam, and now they're getting a PSA test. And there's other studies you can do. So you need to get checked out for that. Colon rectal cancer. It's the third most deadliest cancer in men and the second most common cancer in women. And the advantage is a precancerous polyp takes 10 to 15 years to become a cancer. That's why there's an advantage to screening. If you screen for it, because you're supposed to screen every 5 to 10 years, you'll catch it before it becomes full-blown cancer. So this is even before it becomes cancer. A polyp will take that long. That's why when they do these colonoscopies, they usually snip out those polyps. Even if it doesn't look bad, they'll snip it out. Has anybody ever seen a picture of a polyp inside the colon? It looks like a wavily worm in there. That's why they really want to do it. And the advantage is it takes 10 to 15 years to become a full-blown cancer. And that's why they do it. Screening age begins at 45 years old. You can either do a stool-based test, which means you take a stool sample, or do an exams that look inside the colon and the rectum. That's new, because 20 or 30 years ago, or actually 40 years ago, it was pretty much they stuck a tube up there and they looked to make sure you didn't have it. And then now the stool-based tests are coming into effect. In addition to that, what they found is colon cancer rates are declining in over 50, because that's usually when the screening age started. And they figure it was because they're screening more now. But they also noticed that the colon cancer rates in young adults, like 30, are increasing by 1 to 3%. So every year it's been increasing. So now what they've done is recommend screening age is 45 years old. They're just not going to take any chances. Before it was 50 years old. And risk factors are age, precancerous polyps removed during colonoscopy, family history, chronic inflammatory bowel disease such as ulcerative colitis and Crohn's. So those people need to have their screening done more often. In addition to that, a diet of red or processed meats increases your risk for colon cancer. And if you drink a lot of alcohol, that's another risk factor. And you have a low intake of fruits and vegetables, they also contribute to the risk, possibly due because you don't get enough fiber. And of course, smoking causes the problem. And that's straight out of the Harvard book here. The other one is symptoms of colon cancer: change in bowel movements, diarrhea or constipation, weight loss with no known cause. That's why they're always checking on weight loss. Blood in the stool, and that's red blood. There's also black blood, but this is one that is red blood. And abdominal pain, aches, or cramps, with no clear explanation of why that's happening. The other one is Alzheimer's disease. It's a progressive loss of memory and cognitive abilities. And the leading form of dementia over 60. And about 60 to 70% are over 60. And risk factors include a family history, heart problems, genetics. There's genetic testing for it now. High blood pressure, high cholesterol, obesity, smoking, diabetes, lack of exercise, poor judgment, lack of social engagement are risk factors for Alzheimer's. And it was kind of interesting. I was looking at this slide here. It also includes got added on. Veterans who suffer traumatic brain injuries are 60% more likely to develop Alzheimer's. And so these are the people that experience like a blast injury, like in Iraq or Afghanistan, and they're more likely to develop Alzheimer's because they had a closed head injury, meaning that there was no bleeding, but it just got hit hard in the head. So diabetes, I've spoken so much about it. Diabetes is basically there's not enough insulin or insulin resistance. It's the most common chronic condition in the U.S. And it was left untreated can lead to kidney failure, amputation, blindness, heart disease, stroke. So what you need to do is watch your weight, do physical activity. So it says, this is a conclusion that the Harvard came up with. Regular exercise protects you even if you don't lose weight, but you try to improve your diet. Okay, accidents. Accidents rank as the leading cause of death in young men. The three types of accidents are motor vehicle accidents, poisoning, and falls. And falls account for about 3/4 of all accidental deaths. Now I have to say motor vehicle accidents is a high risk for leading or causing people to die. And so it's basically, it can affect young men and young people and then older people. Okay, chronic kidney disease. Chronic kidney disease, the kidneys remove waste from the bloodstream, control your blood pressure. So people that have kidney disease, their blood pressure is not controlled. They'll have high blood pressure because the kidneys control your blood pressure. And early symptoms of kidney failure include fatigue, increased urination, and decreased appetite. This is early. They're going to the bathroom a lot, and they always feel tired and have decreased appetite. And you can reduce the risk by controlling blood pressure, improving your diet, and become physically active, watch the weight, and control your diabetes. Two leading causes of kidney failure are blood pressure and diabetes. And the other one I already mentioned, limit the use of your NSAIDs. When you use Motrin and Aleve regularly and for a long time, such as ibuprofen and naproxen, it can cause kidney damage. In fact, I think there was an article saying that these medicines the reason we have so many Americans on kidney failure and on dialysis. Okay, obstructive sleep apnea. Okay, this time I'm not going to blame my mom. I'm going to say I have that, and sleep apnea. And it's actually a serious condition. You actually stop breathing, and your breathing becomes very shallow, 100 times per night. So what happens, the upper airway so the upper airways up here, becomes blocked because you have either a large tonsils, or you have fat back there, and it blocks your airway when you lay down flat. So it doesn't usually occur when you're laying on your stomach. That's one solution. But if you lay on your back, you have apnea, or you stop breathing. And usually untreated, this can impair your ability to think clearly and increase chance for an accident or a motor vehicle accident. So they're blaming motor vehicle accidents on sleep apnea. And it can lead, because it causes you not to breathe, raise your blood pressure, heart failure, and stroke. And the oxygen level goes down. Now, I'm going to try to simulate this sleep apnea. So they usually snore. The person that has it is snoring like. But what happens is when they're snoring and they stop, 60 seconds later or 30 seconds, they're not breathing. They go like that. Yeah. So that is basically had an apneic episode where they stop breathing. And so it leads to daytime grogginess, fatigue, and sleepiness. And a lot of times people are heavy on weight, or they have a thick neck. I think that was my reason. 17-inch neck, because I used to be more built up. And it leads to high blood pressure, or you already have it. And the treatment is using a CPAP machine, positive airway pressure, because it keeps the airway open. Or there's a surgery for it. I don't think the surgery is much popular. They used to go back there and take the tonsils out and do a procedure, open the airway more. But now I don't hear that done all the time. So it is a serious condition. Okay, the other one that I want to bring up is persistent menopausal symptoms. It says that some women breeze through menopause and don't have any issues. Some women have years of persistent menopause. And they did a long-term study in 2019 called the SWAN study for all women, all races, all backgrounds, and found that 80% of women experience menopausal symptoms, and which include hot flashes, night sweats, heart palpitations, and sometimes lasting more than 8 years. That includes you can't sleep, you're depressed, you're anxious, you have vaginal dryness. And this slide says the same thing. So persistent menopausal symptoms can last a long time, and 80% of women that they surveyed said they had it. Okay, and there's a big issue to use hormones, estrogen or progesterone. I don't think I can cover it. It covered it on here, but even then it's controversial whether you should have estrogen or progesterone. So estrogen and progesterone would really reduce the menopausal symptoms, but the estrogen and Permin have other side effects. So I guess what they're trying to do is you're trying to balance out the risks that come along with it. So I don't want to get into it. So that's why I put down history of hormone therapy is confusing. The question isn't, this is what Harvard put down, the question isn't how effective the hormones are. The question isn't how effective the hormones are at relieving menopausal symptoms. The question is it's about the risk the hormones can bring on. So is it worth it to take the hormones to relieve some of these symptoms, like what I have up here? Hot flashes, night sweat, irregular periods, irritability, depression, panic attacks, or there's risks that come along with that. So, okay, I don't know how to describe this one. Pelvic organ prolapse. Pelvic organ prolapse. So 1 in 5 women have some kind of pelvic organ prolapse, either uterine, bladder, urethral, or rectal tissue that protrudes into the vagina. So, anybody ever heard of this? You don't have to admit you have it or not. Yeah. So what it is, if you look on this slide, first one on this normal, there's the bladder in the front. So this is the front. This is the back. So that's the bladder and the urethra opening. Here's the vagina. And there's the vagina opening. And here's the rectum and the colon, right here. You can see it. So the first one is the rectal. See how it's enlarged compared to here? It protrudes into the vagina. So if you looked at somebody, I used to deliver babies, and you look in there, in the vagina, and take a look in there, you'll see the rectum tissue. It's not open to it, but it's bulging into the vagina. It's bulging into the vagina. So that's what they call a rectal seal, but that's the first one. The second one, a cystocele, if you look at this normal bladder, see how small it is and how enlarged it is, and it's intruding into the vagina. So the bladder, when it fills up, when you look inside the vagina, you'll see that it bulges in. And it bothers some people when they have that, women that have that. In addition to that, it probably affects the ability for them to pee. And the last one is the uterine prolapse. See, if you look at the uterus right up here, here's the vagina. Basically, the uterus has slipped and gone down, and now it's slipping out through the vagina. That's uterine prolapse. So it's the most common cause of urinary incontinence. We'll talk about incontinence in a second. So basically, you're leaking urine, or you can't push out all the urine because of this problem of this pelvic organ prolapse. And the risk factors are women who've had one or more vaginal childbirth are at the highest risk. Giving birth to a baby that weighed more than 8.5 pounds. Hormonal changes during menopause. So what does that mean? Hormonal changes, when you go through menopause, you lose the estrogen and progesterone, and you're going through menopause. When you don't have those hormones, and that's the reason why sometimes women would be willing to take hormones. The other one is you can try a pessary. It's like a diaphragm. So it's a device. You can look it up on the web. Kegel exercises. And my mom was doing this because she was, I'm pretty sure, when you take care of your mom, and you're the doctor, you will see everything. And I saw my mom down there, and it was coming through the vagina. It was leaking out through there. And you can also do physical therapy, and physical therapy will help you with the Kegel exercise. My mom had the Kegel exercises translated into Chinese so she could figure out how to do the exercises so she wouldn't have that issue. And I remember she did it faithfully for about 3 or 4 years. And finally, there's the hysterectomy. The hysterectomy, just to take out the uterus. And that doesn't solve, well, it does solve it, because if this uterus was gone and the vagina was closed off, the bladder can't come in as well, and the rectum can't come through. Okay, I think I talked enough about that. Okay. All right, I can talk about other things. Hysterectomy. Okay, there's many cases of ovarian cancer that originates in the fallopian tubes. So I'll say that again. The cancer, if you look at this picture here, fallopian tube removal can reduce ovarian cancer risk. So they don't take the ovary out, but they take out the fallopian tubes. The fallopian tubes is where the egg, when the ovary gives an egg out, it travels through the fallopian tubes. And actually the sperm can sometimes catch up over here too, but it should catch up down here in the uterus and the vagina. Vagina's down here, uterus is right there, and then the ovaries, obviously 2 ovaries, 2 fallopian tubes. And so they found that ovarian cancer is one of the most deadly cancers because it's always caught late. Like when I was in primary care, when I gave a pelvic exam, I was faithful. I tried as hard as I can to feel the ovaries and make sure that that the ovaries were not enlarged. And if there was any question, I ran an ultrasound. I said, we're going to run an ultrasound. If I can't feel it, I better make sure. It could be because I couldn't feel it. It's not because it was small and not enlarged. So when the ovaries get large, it's a big deal. Because when they get large, that means they could have ovarian cancers. So in 2019, there are two studies, 2017 and 2016. They found that removing the fallopian tubes and leaving the ovaries behind, they actually reduced the risk of cancer in a lifetime by anywhere from 42 to 78%, or a lifetime cut by half. So now it's not just removing the uterus and removing the ovaries, and now they're not going to remove the ovaries because they think the ovaries can give out hormones that keep you from having the severe menopausal symptoms. They take the fallopian tubes out. They think the cancers from ovarian cancer is coming from the fallopian tubes. And so that's why I kind of brought this up, and that's why this book on men's health, or women's health, excuse me, talked about this, because if you're thinking about having a hysterectomy, you have to talk to your OBGYN doctor to talk about the possibility of removing the fallopian tubes and not the ovaries, or take out the ovaries and the fallopian tubes. So that's an important thing to talk about, because this issue will be popping up. Okay. So ovarian cancer, although not in the top 10 list of most common cancers, ovarian cancer is responsible for more deaths in women than any other reproductive system malignancy. So it's not as common, but there's more deaths from it in women. It's most feared because it's not detected until the disease has spread elsewhere in the body, meaning it's metastasized. It's spread to somewhere else. So it makes it hard, particularly in primary care, because you can't catch it well enough, and you may have been the one that should have caught it, and then by the time it spread, it's deadly. So they want to catch this as early as possible, and our pelvic exam, our hand exam, can miss it, because what you're doing is usually you have your hand in the vagina and your hand on the abdomen wall, and you're trying to palpate to see if it's enlarged or not, and it's difficult, particularly somebody that might have extra soft tissue that you can't find it. So whenever I couldn't find it, I just got an ultrasound just to be sure. It may cost more. Anyway, so the warning signs of ovarian cancer, unfortunately, are not specific. Abdominal pain or bloating, pelvic pain, difficult eating or feeling full quickly, meaning that you ate and then you feel like you're full, and urgency like you want to go to the urinate all the time, and you have frequent urination. And you can see that's very subtle. So this is a slide from American Cancer: bloating, pelvic pain, difficulty eating or feeling full too quickly, urgency or frequency, meaning you want to go to the bathroom all the time. So ovarian cancer, median age of diagnosis 63, a family history, postmenopausal estrogen use. So what it comes down to is you shouldn't just use estrogen alone. 5 or more years of estrogen without concomitant use of progesterone puts you at higher risk. So if you just took the estrogen alone, because your ovaries produce that, and you took it artificially, and you did 5 or more years, it puts you at higher risk. And the reason I bring that up is because if you're in one of those categories, I would check more frequently for have a pelvic exam. This is not the Pap smear. The Pap smear checks for cervical cancer. This is for ovarian cancer. Okay, incontinence. As I said, we're going to talk about it. This is the unintended loss of urine or feces. So I'll just say this. I don't have that, but my mom had it. She was losing stool all the time. And I think it contributed to her desire to go on hospice. So she was already losing urine, but she wore a diaper for that. But the feces was a bigger problem. And so basically, even if it was urine, you're getting up several times each night to go to the bathroom. So my mom wouldn't drink water, particularly at night. And you're risking, because you're getting up all the time, there's a chance that you may get less sleep and have an injury from falls rushing to the bathroom. And somebody sat down and did a study on it. When you're going to the bathroom and you're rushing to get to the bathroom, there's 26% risk for fall and 34% chance, 1 out of 3, to break a bone. So that's from the urine. And so it's called stress incontinence when the urine leaks when you exercise, or you're running, or bending over, or sneezing, or coughing. So if you cough or sneeze, the urine comes out. It's called stress incontinence. Urge incontinence means the bladder, where it holds your urine, contracts suddenly before the bladder is full, and there's leaking of urine before you get to the bathroom because you have no idea that your bladder is full or not full. So those are the two types of incontinence. Sometimes people have a mixture of both. And this men have it because of their prostate. And women have it because, well, probably the organ prolapse too. So it says 1 out of every 3 people have incontinence on that slide. And so urinary incontinence, the treatment for it is bladder control training, fluid management. So like my mom didn't want to go to the bathroom. She wouldn't drink fluid at night. Pelvic muscle strengthening. So they're strengthening the pelvic muscles down here and seeing if this would help. So there's some more muscle tone. Weight loss. And there's medications, pessaries. I don't know if you've ever seen one. They're on the web. You can see it. You can try Botox. And you can also do, this was new to me, electrical stimulation. And I'll just read this. Percutaneous tibial nerve stimulation. Percutaneous meaning it's just below the skin, it's around the skin, and it stimulates the sacral nerve, and there's a permanent one that you put underneath the skin. But you can see what they're doing right here. See, this is the ankle, that's the foot, and there's a patch here. And you're stimulating the tibial nerve. The tibial nerve is right down here. And it runs all the way up to the sacral nerves on your behind. And it lessens your urge to go to the bathroom, do number 1. So this is new because they didn't have that. We're not learning it. And they also have one where you can permanently put it underneath your skin, probably around the buttock area. But this one is where you attach it to you so you don't want to go to the bathroom. I've never used one. I kind of wish I had known about it when my mom was still alive, and I think would have helped because the doctors I took her to didn't know anything about it. Yeah, I would have taken that chance. Another one's ejection of collagen around the urethra to create a tighter seal between the bladder and the urethra. So the bladder's here, urethra's the opening, and you inject collagen. Collagen is the same kind of stuff you inject for some people for cosmetic reasons, and it tightens the opening. So there's basically the opening will be squeezed down more because there's fluid in there. I mean, not fluid, there's collagen. There is a surgery, highlighting it, bladder suspension surgery to raise the bladder and urethra with a sling of tissue or mesh. The use of mesh has complications. I've heard of that. And so usually you use your own tissue. That's the tissue you're born with, and they suspend the bladder and they basically strengthen it up so there's less likelihood. That's a surgical solution. And the surgical solution actually works pretty well, but that means you have to go through surgery. It's probably better to try conservative measures. Next one, this is called fecal incontinence. So it means that if you cough or sneeze or something like my mom, she would have stool coming out her rectum through the anal sphincter. There was literally no tone to her anal sphincter. And you know, when you take care of your mom, you have to help them. You have to help them wipe. Becky and I were doing it. Take care of her, and so we see this. So basically, the ways to try to treat this is, one, control the diarrhea with fiber. So make the stool better. It's not listed on here. We were trying medicines like what's the diarrhea medicine? Lamoto. Or, you know, there's a medicine called Lamoto. It slows down the colon from, basically it's like you're having diarrhea. It slows it down. The other one's doing Kegel exercises. And amazingly, when they did studies on it, the Kegel exercises had 75% improvement and 50% complete relief. My mom didn't have that, but she didn't try that. Or she did try that. This is another one. This is new to me too. Electrical stimulation of the pelvic floor muscles. So what they did is they have a device, an implant on there around the sacrum, and it stimulates the sacral nerves. The sacral nerves cause contraction of your anal opening in the rectum, and it causes it to tighten up. And it says it has about 88% reduction in incontinence. The next one, I've never heard of this one either. Magnetic stimulation of the pelvic floor muscles. And there's a magnetic chair, and that's the chair. And it stimulates the same nerves, sacral nerves, with an external device. So I would have tried that one for my mom. Just to put her on the chair that had the magnet on it and get the sacral nerves to stimulate, and so there's less, because that was what she was most embarrassed about. And then there's surgery to correct rectal prolapse, raise the pelvic floor muscles, and reshape and repair and replace the anal sphincter. I took her to the best guy I had here in the Tri-Cities to look at this, and he could not offer me any surgery, and he didn't know these two devices right here. So at least you know, you hear about it now. So if you ever have to take care of somebody that might have it, or hopefully you never have it yourself, you know there's some devices like this. Okay, my mom also had this one too, dry eye syndrome. So your tear production declines, and it causes burning or irritation of the eye. There's 70% that are women. Men don't seem to get it, but women do get it, probably related to hormones. And what they have is, you read, their redness, and also a lot of times they tear a lot because their eyes are irritated and they're itchy. And those are exactly what my mom had. And so we put artificial tears, and she used this anti-inflammatory eye drop called Zydra, and that did work. It's a common thing, dry eyes in women. Next one is osteoporosis. So this is because there's bone loss and the bone becomes porous. See the bone on the left, that's normal, healthy bone, see? And osteoporosis meaning the bone walls and density have decreased significantly. So it makes it more, more fragile. And women are more likely to develop osteoporosis. And bone loss begins earlier and more rapidly in women than men. Men seem to hold on to their bone, but women seem to lose it. And it's tied to the menopause. Without the estrogen effect, they seem to lose bone. So the solutions are calcium, and you should take at least half of it from food sources like leafy greens, and vitamin D. And I'm a proponent of this one, weight-bearing exercises. By the way, osteoporosis affects men too. So weight-bearing exercise means that you walk and try to increase the bone density by exercising. Even walking helps. And then there's medications to help, which are called the biphosphonates, like Fosamax. I don't know, anybody heard that one? But osteoporosis is important. And after the age of 30, your body loses more bone than it creates. Petite women and men have a greater risk of developing osteoporosis. So if you're thin and skinny, you have more chance of it. If you're heavy, then you have less chance of osteoporosis. And there's a scan for this, a DEXA scan, for women above 65 and men above 70. So anybody above that fits that criteria needs to have a DEXA scan. And also, another problem that seems to hit women more often is foot problems, because the woman's foot will become wider and longer as they age. And they won't have as much fat. And they will end up with what we call, bunions. I don't know if you know what that is. That's where the big toe swings outward. And plantar fasciitis, so that's real common, and hammer toes and neuroma. And there is surgery for this, but you prefer not to have it. And another solution is not to wear high heels that have narrowing of the toes at the very top. You know, where it boxes the foot in, the toes in. And 90% of the foot surgeries are performed on women because of this problem. Okay, I'm just going to go through this one real quick. There's a thing called melanoma. It's the most deadly form of skin cancer. Only 1% of the skin cancer diagnoses are melanoma, but they comprise nearly the majority, greater than 50% of the skin cancer deaths. It's exposure to sun and sometimes not. And risk factors include sunburns or tanning beds. It is caused by ultraviolet light. And if you have one session of an indoor tanning bed, it can raise your risk by 20% for melanoma. It's at risk for people that are fair-skinned, are freckled, light hair, and eyes. And so if you have moles that start appearing after the age of 30, you have to be careful. And this is how you can spot a melanoma. I'm not going to go through all of it. If it's asymmetrical, the borders are irregular, colors changing, diameter that's increasing, or it changes from 1 to 2 or increases in size. See this one? It's the big toe. If you saw this, this was a melanoma underneath the toe. It gets confused a lot, so be careful for melanoma. Breast cancer, the only thing I know a lot of people have it. So what the idea, breast cancer is a risk. So you have to follow the mammography screening guidelines. And so what the recommendations is, the American Cancer Society recommends mammography routine screening at age 45 to 54 annually. But there's also recommendations you begin at age 40 to 45 every year. And then after 45, you can have it every 2 years. And to catch it early is really important. Okay, I've covered a lot of stuff. I'm hoping I'm helping you understand a lot of the issues that people have for healthy reasons. And I felt it was really helpful because I wish it had been in one place. And whenever you get a physical and talk to your doctor, you really need to be aware of all these issues I brought up, because these are the things that you want to focus on, particularly if you're at risk for it. And as always, we have to have faith and trust in God. And this is the most important law to put into practice every day. Okay, that ends this talk. I did want to show you one more slide. Next month, we have Dr. Juno Chow. He's from the Northwest Cancer Clinic in Kennewick. And he'll be here talking about how to prevent cancer. And so I think he's a very good speaker, and he's well qualified. Okay, is there any questions here? That's a lot of information. All right. Yes, that would be helpful. Yeah. Yeah, I agree. All right, I think that's about it. I'm going to do a closing prayer here. Dear Heavenly Father, please bow your heads. Dear Heavenly Father, thank you so much for allowing us to get together and learn more about health issues that affect us all and how we can intervene early and make changes that allow us to have a more fulfilling life and less chronic illnesses, less suffering. Thank you for all the times you've helped us in the past, and we really appreciate all your blessings that you provide us. In the name of Jesus, amen. Yeah.